All right, so good morning again, everyone. Thanks for joining. It's my honor to introduce Dr. Eugene Choo to give this talk on food allergy testing for eosinophilic esophagitis and beyond. I have been really looking forward to this talk for a question that very commonly comes in our practice from our patients, and I really hope to take some polls home today. So Dr. Choo is an associate professor of medicine in allergy and immunology at UCSF. He completed his internal medicine residency at Baylor College of Medicine and did his fellowship in allergy and immunology at National Jewish Health in Denver, Colorado. He stayed on as faculty there for some time and worked in Houston for a couple of years as well. And then we were fortunate to have him here as faculty at UCSF. We are very excited for your talk, Dr. Choo, and please feel free to share your screen when you're ready.
Okay, great. My screen, hopefully everyone can already see it.
Yeah.
Okay, all right, wonderful. So thank you, Dr. Singh. And so yes, today I'll be talking about food allergy testing for eosinophilic esophagitis and beyond. And I actually did not pick the title of this lecture, but I will say I kind of liked it. It kind of gives me some Buzz Lightyear vibes, I thought, but let's go. So first of all, no relevant financial disclosures to report, and learning objectives here. So I'd like to review kind of the scope of adverse reactions to foods, because there's a wide gamut out there, non-allergic and allergic. I want to talk about some food allergy testing modalities and when we decide and how we decide to use them. And then lastly, I want to focus on the role of foods and food allergy testing in EGID, eosinophilic gastrointestinal diseases in particular, with a specific emphasis really on eosinophilic esophagitis, or EOE. So going ahead and getting started with a clinical case here. So first we have a 28-year-old gentleman, has a history really significant only for chronic allergic rhinitis, comes in as a consult for evaluation of progressive dysphagia over the past 5 years. He said that first this dysphagia was only really to large chunks of meat, but over time this has progressed and now smaller foods are becoming problematic as well. He also has some GERD type symptoms, some substernal burning, some acid rash. And so the question here for us is, should we perform food allergy testing? Should we advise an elimination diet? And if so, which foods should we be thinking about here? I'll go ahead, and since we have, I think, a meeting over Zoom, I can't really call on people or ask people to raise their hands, so we can just kind of move on and kind of see if we can kind of come to some kind of answers here. So first of all, just some background, kind of a primer in terms of allergy immunology for the majority of the audience who I suspect is not going to be in AI. So we have some primary methods of testing for food allergy. First, we have percutaneous skin testing, which is very, very sensitive, but very, very non-specific. And it's useful for basically IgE-mediated food allergy, which we'll describe in some more detail soon, as well as potentially for EGID. We'll talk about also food-specific IgE or serologic testing, which, like the skin testing, is also sensitive, but not very specific. There is sort of a subset of this serologic testing, component resolved diagnostics, looking at sort of the exact component of the food molecule. And that's becoming more and more utilized in our field. And this is useful for IgE-mediated food allergy. And then kind of the last sort of main modality we have here is going to be the oral food challenge, or OFC. And it's going to be useful for both IgE as well as some non-IgE-mediated food allergy, with one example being FPIES, or food protein-induced enterocolitis. But we'll kind of dive into more detail with all of this here. Broadly speaking, when we as allergy immunology doctors see someone coming in with a complaint about adverse reactions to foods, there's really sort of three large buckets that we're thinking about. So really they sort of fall into allergic, not allergic, and then basically not real. Sort of the allergic category, of course, is going to be the most important one for us. And we think about IgE-mediated food allergy. We think about non-IgE-mediated food allergy. And then we also think about the sort of mixed reactions, including EGID, and then potentially the effects of foods on an entity like atopic dermatitis, aka eczema. We also have non-allergic adverse reactions to foods, some of which I'm sure that in GI are very, very familiar with, so including FODMAPs intolerances, sulfite sensitivities, aldehyde dehydrogenase deficiency, G6PD deficiency. And then in terms of that not real category, that might be overstating a little bit, but I should maybe say at least unproven. And these are things like histamine intolerance. And this is one of the things that unfortunately we see quite a lot of in adult allergy immunology clinic, is this sort of not real food allergy type of a picture here, or not even not a real non-allergic issue either. We see this quite a bit more, unfortunately, than our pediatric colleagues do. So first of all, starting with the non-allergic adverse food reactions. So these are generally very, very real, but they're not because of an immunologic reaction to the food. But it's really more typically the symptoms that are encountered because of difficulty digesting or metabolizing a food. And as you might imagine, food allergy testing here is really not the answer. So some of these examples. So as I had mentioned earlier, so FODMAPs, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. This is one of the most common things that we will be getting questions about and consultations about, at least from sort of our primary care practitioner population. And patients will present with typically and oftentimes in the setting of irritable bowel syndrome with a variety of very, very, I'm sure, familiar symptoms for your specialty: bloating, gas, abdominal pain, diarrhea, after a wide range of foods, fructose, fructans, galactans, lactose, polyols. This is something that patients will have real suffering from, but it's not, once again, it's not a food allergy, and it's really just the result of poor digestion, poor absorption. We've got aldehyde dehydrogenase deficiency, kind of that characteristic flushing after alcohol, especially in individuals of Asian background, typically. We've got things like sulfite sensitivity, which doesn't occur in most of our asthma patients, but in a small minority of our severe asthma folks, they will encounter some wheezing if they ingest very, very high sulfite foods, characteristically things like red wine, instant mashed potatoes, things like that. Then we have G6PD deficiency, patients who suffer from hemolysis after eating certain characteristic foods with high oxidative properties. The fava beans being kind of classic, but other things sort of listed there, like red wine, legumes, blueberries, soy, tonic water. And then sort of more controversially, definitely not as clear, is going to be sufferers of migraine headaches, which potentially, at least in some studies, and less so in others, may have their symptoms triggered by biogenic amines, things like alcohol and chocolate. Now, sort of switching gears here now to the allergic adverse food reactions. Once again, there's sort of the IgE-mediated, there's the non-IgE-mediated, and there's sort of a mixed picture ones. And so kind of first starting off here with the IgE-mediated, which is going to be the kind of classic food allergy, the more common reason for consultation to our service. And so this is really representing a type 1 immediate hypersensitivity reaction. Usually the symptom onset is very, very, very fast. So typically within 30 minutes, oftentimes much less than that, can be life-threatening. And as you might guess, food allergy testing here becomes of the utmost importance. So in this category, though, of IgE-mediated food allergy, so there's sort of the immediate or sort of classic food allergy there at the top, but also some other entities we think about, including oral allergy syndrome, pollen food allergy syndrome, latex cross-reactivity, food-dependent exercise-induced anaphylaxis, and then this meat delayed allergy or alpha-gal. So I'll kind of go over this in a little bit more detail here. So first of all, the most prototypical, the most classic food allergy, this sort of immediate hypersensitivity reaction. This is going to be occurring more often in the pediatric population than our adult population. And really about 90% of these true food allergy reactions are going to be to these so-called big 8 foods, or sometimes we call them the big 6, depending on how you break it down. But it's basically milk, egg, wheat, soy, nuts, and seafood. And so once again, this does comprise about 90% of food allergies in the country. And so when folks come to us with complaints about potentially being allergic to a food outside of those big 6 or big 8, it is something that we will be automatically a little bit more suspicious that it might not be necessarily a true IgE-mediated food allergy. The other thing about this entity is that about 50 to 80% of these true IgE-mediated food allergies resolve by the time a person's about really hitting sort of 3rd grade. That's for most of the foods. Unfortunately, the nuts, peanuts, and tree nuts are likely to be there for life, along with seafood. And if an individual is going to develop a new food allergy as an adult, then seafood and shellfish in particular is the most likely entity, really. Once again, as a true IgE-mediated food allergy, the testing modalities are all going to be very, very useful and effective for this, and very, very important, because we really will want to know what is this person truly allergic to, and do they need to be strictly avoiding it? Do they need to be carrying an epinephrine injector? All of that sort of thing. And so we'll typically be doing skin testing, serologic testing with specific IgE, and then sort of the gold standard for this is typically going to be an oral food challenge, which can be done either in our office, or if it's a very, very low suspicion, low risk sort of scenario, they could potentially do it at home. Next here, just kind of touching on a few of these other IgE-mediated food allergy entities. So there is oral allergy syndrome, which is really the most common food allergy syndrome we see among adults. And so about 5% of the adult population has this to a certain extent. And basically, there's going to be an itching, sort of tingling, unpleasant sensation in the mouth, lips, tongue, throat area when these individuals eat certain raw fruits, vegetables, nuts. And it's not because they're directly allergic to the food per se, but it's really because of an underlying pollen allergy. And so that kind of that chart there sort of lists some of those relevant cross-reactivities. And once again, this is extremely common. So some people in the audience may actually kind of recognize these symptoms in themselves here. But for example, if someone is allergic to things like birch tree pollen, then you might get an itchy mouth, lip, tongue, throat when you're eating things like apples, cherries, celery, that sort of thing. And one of the telltale signs of this is going to be that when the food is cooked, then typically the symptoms tend to resolve as the heating breaks down those kind of the tertiary protein structure, and then the food no longer looks so much like the pollen. So a common story we'll hear is someone will say, if I try to eat a freshly kind of picked apple, then I can't do it at all. But if I take that same apple and then bake it into an apple pie, all of a sudden it's just fine. And so that's really one of the obvious history clues for us to know that this is really oral allergy syndrome. And even though I did say that it's usually pretty kind of mild and self-limited with that oropharyngeal pruritus, unfortunately, about 1 out of 10 to 1 out of 20 times, someone can develop more severe systemic symptoms. So it is something that we don't want to ignore, and just we do want to be on the lookout to see if someone's maybe potentially having a more severe presentation of this. And when we see these individuals, we're thinking about doing food testing if we're trying to determine if this is really more of a direct food allergy or more of a pollen cross-reactivity. But as you might imagine, we're also typically doing aeroallergen testing as well to see if there is some underlying pollen sensitization that might explain their symptoms and their history. All right, next, some kind of rare IgE-mediated food allergy conditions, ones we don't see nearly as often, but definitely are out there. So there's food-dependent exercise-induced anaphylaxis, or FDEIA. And this is kind of an unusual condition where someone can eat the food and be fine, and someone can exercise and they're fine, but they can't do the two within too close temporal proximity. And so when this happens, then this actually happened to a friend of mine in med school. He was fine when he ate shrimp, and he was fine when he played basketball, but he couldn't do the two activities within a couple hours of each other, or he actually went into anaphylaxis on the basketball court one day as we were playing pickup. So this definitely does happen. And to determine if this is present, there's certainly going to be some skin and serologic testing we can do, but ultimately a food and exercise challenge is sometimes necessary to really definitively diagnose this. Another thing that we are aware of and that has had increasing prevalence, unfortunately, is going to be this reaction to meat, which is delayed, or this reaction to a specific component of meat, galactose, alpha-1,3 galactose, or alpha-gal for short. And so this is sort of the unusual kind of black sheep of the IgE-mediated food allergy family, because the symptoms are so delayed. The other symptoms typically occur very, very soon after ingestion, as I mentioned, but this one can occur up to 6 hours after eating that piece of meat. And it's thought that's mainly due to the way that the particular meat proteins are broken down as opposed to like the carbohydrates of the other foods. And oftentimes the sensitization to meat occurs after a bite to a certain type of tick, where at least in the US, the Lone Star tick is the predominant factor. In other countries in the world, this is also found, but it's a different specific bug. But in the US, it's the Lone Star tick, which has a main sort of distribution throughout the southeastern United States. So not really a major problem, thankfully, in Northern California. And diagnostic testing for this is going to be skin and serologic testing typically. In theory, one could do an oral food challenge, but once again, because it's the long delay before symptoms occur, it's just not very practical to have someone come in and sort of sit around for hours and hours and hours waiting for something to happen. Another entity, latex food cross-reactivity. This is less common, as sort of latex sensitization has decreased over the years with better manufacturing methods for personal protective equipment and more non-latex gloves, that sort of thing. But there's some classic associations with latex, and then some of these foods like banana, kiwi, avocado, chestnut, and testing skin and serologic can bring this out as well as theoretically also a food challenge. Now, kind of switching gears here a little bit, we've got the non-IgE mediated adverse food reactions. And so I kind of put pediatric division here just to sort of kind of emphasize that these are conditions that I myself and other adult allergy immunology docs really rarely see, because these are really affecting typically infants and toddlers. And so here we've got FPIES, the food protein-induced enterocolitis, the food protein-induced enteropathy, and then the food protein-induced allergic proctitis or proctocolitis. And so these have a range of symptoms varying from sort of more or less asymptomatic bloody stools, all the way to having really severe, profound diarrhea that can even be potentially life-threatening because it can cause shock in infants. And so something that we do see, not, like I said, that often for the adult allergy immunology clinic, but I know that my colleagues in the pediatric allergy department definitely see these not too infrequently. And so the mechanism is not entirely clear, but the thought is basically there's going to be some T-cell mediated local inflammation after this ingestion of food allergens. And then because of that local inflammation, there's increased intestinal permeability, and then those fluid shifts can be drastic and, like I said, potentially even life-threatening if it's happening in a small enough infant and there's enough fluid loss. Diagnostics for this, because it's not IgE mediated, this is a situation where our skin and serologic testing is not going to be helpful. It's not effective. And so food challenges become really the only way to know for sure. And now we get to the sort of category of allergic adverse food reactions that's mixed, some component of IgE and non-IgE mediation going on here. And this is going to be the Egypt category, really, with EOE, or eosinophilic esophagitis, being the most famous of the group for sure. But then we've also got the gastritis, the enteritis, and the colitis. And so kind of one big question, first of all, that our patients often ask is going to be, so I've got this Egypt condition. Does the food allergy even really matter? And certainly there's a lot of strong evidence that it does. And so in many studies, we've seen that there's a large percentage of the population who, first of all, have another relevant allergic disease, whether that's going to be also a pre-existing history of food allergy, drug allergy, atopic dermatitis, rhinitis, asthma. And we see this also similarly, not just for EOE, but for other EGID conditions, about 50 to 70% have another allergic disease ongoing. And there's some other clues there, sort of when you're doing sort of serum tests, where you can see that over half of our EOE patients have some degree of elevation in their serum IgE levels. Not typically incredibly high, but definitely somewhat elevated. And also the same holds true where about half of our EOE patients have some degree typically of mild peripheral eosinophilia. And so real quickly, definitely don't want to dwell too long on this because I know, once again, this is a GI grand round, so you will know this better than I will. But for EOE, definitely just in terms of the background, so first cases were reported in the late 60s and sort of has been a gradually increasing prevalence over the years since. There is a male to female predominance with the mean age of diagnosis 34 years of age, with unfortunately about a 5-year lag time to diagnosis. And sort of some characteristic symptoms with dysphagia being predominant typically, but as it progresses, they can be food impactions. And there are also some other symptoms people complain about, including some sort of refractory heartburn type symptoms, chest pain, abdominal pain, that sort of thing. And diagnostic criteria, really, first we need to see that there are symptoms due to this esophageal dysfunction. Second, we need to see at least 15 eosinophils per high power field, typically on esophageal biopsy. Ideally, the biopsies are taken from multiple sites. And then lastly, exclusion of other etiologies that could be causing those number 1 and number 2. And so in terms of the mechanism of what's happening here, it's not 100% completely elucidated, but there definitely is the basic general understanding now that these food proteins are presented to T cells, and that these T cells basically start producing this inflammatory cascade, things like IL-5, eotaxin-3, and this recruitment of eosinophils to the gut. And that eventually, because of these eosinophils being in a place where they shouldn't be, along with other entities such as mast cells, there's a secretion of these other important molecules that then start to promote the characteristic inflammation and remodeling of tissue that we see, that then generates the fibrosis, the dysmotility, and then all the relevant symptoms they encounter. Treatment-wise, really acid suppression is a big part of this, typically. So PPI treatment, oftentimes high dose, corticosteroids, oftentimes utilizing really asthma inhalers, things like budesonide or fluticasone perhaps, that are then on purpose used in sort of what's considered to be sort of bad technique if you're trying to use it for asthma, but good technique if you're trying to coat the esophagus. Dietary modification, which is kind of really the kind of focus of what I'll be trying to talk about here. And then I did want to mention, however, that sort of hot off the presses somewhat is dupilumab, monoclonal antibody blocking the IL-4 receptor alpha subunit. So basically then blocking downstream IL-4 and IL-13 because they share that common alpha subunit. And that was just approved last month. And so this is now our really only official FDA-approved treatment for EOE, more or less. And so in terms of EOE dietary treatment, and all of this is going to be relevant because we'll talk about first what the treatment is, and then based off of that, why it makes sense or maybe not makes that much sense to do allergy testing in our EOE folks. So really sort of three big entities we think about with EOE dietary treatment. So first of all, we've got the empiric elemental diet. And this is the most effective. And then basically you're no longer eating real food, as you can sort of see from that can over there. You're basically just eating formula, these sort of essentially amino acid formulas. So it's the most effective, but by far the least tolerable, especially for an adult. And so it's not the most popular choice, as you might imagine. Second here, we've got the empiric elimination diet. And this has come in various forms, with kind of a 4-food elimination diet being the most common, which in that case, patients will avoid milk, egg, wheat, and soy. But there are many variations on this. Kind of a stricter version is going to be the 6-food, where they're avoiding, once again, like I said, depending on how you break down the foods and describe it, the big 8 or the big 6 most common food allergies in the country: the milk, egg, wheat, soy, nuts, and seafood. And then there's some other varieties out there as well, including a 2-food elimination diet, typically milk being one of them, and then the other food being somewhat different depending on which study you look at, and also even which country they're doing it in. And then sort of the milk alone elimination diet, because milk is typically the most common offender that helps drive EOE. And then lastly, we've got the allergy testing directed elimination diet, which is going to kind of be the most relevant topic here for us now. So in terms of which one to choose and what the evidence really says, so a lot of studies have been done over the years, and kind of one of the most important ones and most recent ones was this very, very well done, very large meta-analysis and review in 2020. And basically, as you can sort of see, that they did see that there was the most efficacious form of diet here was that elemental, really, really horrible amino acid powder diets. The empiric elimination diet sort of came in second place. And then somewhat sadly, the allergy testing directed diet came in third. And so then that sort of begs the question, if empiric elimination elemental diet's the best, and then that beats out the empiric elimination, that beats out the allergy testing directed diet, why even bother with the allergy testing? This is actually not that clear-cut an answer, but there are definitely, and actually depending on the studies you read and depending on which society's guidelines you look at, some people are going to be coming out with stronger recommendations for or against utility of testing. And so this is not something that we have 100% consensus on really in our allergy world, but there are definitely some fairly relevant rationales that have been posited in terms of why maybe that it does make sense to do food allergy testing. So first of all, there is potential avoidance of fewer foods, which is really, really important, especially for our adult patients who are already completely miserable that they're having to give up so many of their favorite things to try to treat their EOE. And so if they're having to avoid, say, only 1 or 2 foods instead of 4 or 6, you might imagine that they're quite a bit happier about that, even if they are maybe going to be giving up potentially some efficacy. And then second, depending on sort of the size of the food allergy panel you do when you're testing these folks, you may potentially identify a less common food trigger that would have been missed if they just sort of empirically jumped into a 4-food or a 6-food elimination program there. And then lastly, there is possibly a risk of unmasking an IgE-mediated allergy after you eliminate the food and then reintroduce it. And this is kind of a phenomenon that we see really maybe more important in the pediatric population, but there is a phenomenon where a person can actually get sensitized to a food and develop a new food allergy if they avoid the food for a long, long time. Once again, this is more commonly seen in kids, but that is something that you may want to know about with food allergy testing so that you can sort of identify what the problematic food may be. And the same sort of data and the same sort of rationale is seen not just for EOE, but for other non-EOE EG conditions. And so once again, getting back to that, really that question. So food allergy testing, it's not 100% black or white here, and it's not always done. And you're going to see definitely some differences stylistically among different institutions and even among different physicians at the same institution. There is definitely quite a bit of evidence that it does appear to be more useful and more helpful in the pediatric than the adult population. And even when it is done, the extent in terms of how broadly someone casts their food allergy net is going to differ from doctor to doctor. And so you'll see some physicians who do very, very broad food allergy panels, and they'll test an individual for basically every single food they can test them for, so maybe close to 50 foods when they see they're coming in for EOE. And then there will be other physicians who are going to choose to mainly test the so-called big 6 or big 8 foods and just stick to that milk, egg, wheat, soy, peanut, tree nut, fish, shellfish panel. Now, one interesting note here for EOE is that, as I mentioned earlier, with food allergy testing, when we're thinking about our usual classic IgE-mediated food allergy, the skin testing and the serologic testing are both good, and they're usually fairly interchangeable, although oftentimes we'll actually do both. But in EOE, really the skin test is the one that's really been shown to have the main benefit and not so much the serologic testing. In terms of the food allergy testing, another sort of really important point here is that the negative predictive value is better than the positive predictive value, which is only about 44%. And so it really helps you more to know that a skin test is going to be negative than to know that it's positive. There are some other really less well-validated or not validated, even like I could say, food allergy test methodologies out there for EOE. And some of these are going to be done more often than others. One of the big ones is going to be food ATP patch testing, or the sort of patch tests. And this is going to be a technique where you basically are treating the food almost as if it's a contact allergen, because the underlying idea is that the main driver of this is, once again, this is a T cell or Th2 cell mediated phenomenon. And so you're really trying to pick up type 4 delayed hypersensitivity there. And so you would place patches with so-called fin chambers on the patient's back. And the fin chambers are basically just food put into tiny little chambers that are taped down on the patient's back for a period of 2 to 3 days, and then taken off and then read and just interpreted at that time. There's been some data suggesting some utility for FPIs as well as EOE, but definitely this is far from being standardized, really still pretty far from being validated. And it is definitely fairly time and money intensive to do. So it's just not something that's really widely done. You're going to see it done every now and then, typically more so in potentially like in research protocols than in sort of regular clinical practice. Another test modality that's been definitely in discussion and has been a few papers on is going to be food-specific IgG4, instead of looking at our usual food-specific IgE. And there is some evidence that IgG4 may be more relevant and more important in EOE than the food-specific IgE, which, as I said before, is just not really all that helpful. And this is kind of a paradigm shift for us as allergists in terms of thinking about this, because usually we are really always wanting to just ignore the food-specific IgG because it's usually quite meaningless. And the vast majority of the time when patients bring in these sort of kind of commercially purchased food sensitivity tests, things that they can buy over the internet or something, where it tells them that they'll be able to find out what their food sensitivities are by just paying $200 to $300 or something like that. Those are usually food IgG tests, which are for the vast majority of folks completely worthless, but there may be something to their utility of IgG4 in the setting of EOE. There's some other testing that's been done, but certainly far from ready for prime time in any sense of the word. Is going to be intraesophageal injections or esophageal prick testing, which sounds a little bit crazy, but that's exactly what was done in this one study by Warners et al. In 2018. Basically injected a food allergen into the esophagus of 8 patients with EOE during EGD, and then went back later and looked at sort of how much inflammation was at the sites of those food injections to sort of determine maybe what problematic etiology of their EOE might be. And then lastly, we have sort of T cell stimulation, basically incubating T cells in the presence of certain food proteins. And this is thought to maybe be potentially more useful in our really kind of more exclusively non-IgE mediated food allergy entities. And so FPIs being maybe kind of a classic example of this one here. But once again, this is not easy to just sort of get in a regular clinical practice. You're not going to be able to order this test off of any sort of standard lab panel. And so definitely strictly really at this time, it's going to be more of a theoretical research type idea. So kind of going back to that clinical case of ours that we started with here. So that 28-year-old gentleman, as you might have already guessed from the story, he had a pretty classic history for EOE. His EGD ended up showing more than 50 eosinophils per high power field in multiple biopsy sites in his esophagus. And on his skin testing, just checked the big 8 foods, didn't do a broader panel than that one. Did see a little bit of reactivity for egg, a much more minor reaction to milk. And after a lot of discussion with the patient in terms of pros and cons and just kind of how much disruption he was willing to tolerate in his dietary life, he opted to try the 4-food elimination diet and felt that would be more sustainable than the 6-food, which would have added on having to also avoid seafood and nuts. All right, so in summary, first of all, wanted to emphasize that the adverse food reactions represent a diverse range of entities. There's allergic and non-allergic both. And for our non-allergic adverse food reactions, even when they're legitimate, food allergy testing is generally not helpful for them. And so generally, it's not going to be something that you're going to want to order for those patients. And when they ask you to do testing for something that's, say, somewhat quite clearly FODMAPs intolerance, then really the best course of action is really to not order their food allergy testing, even if they really, really want it. Just because the food allergy testing, as I sort of mentioned earlier, has a very, very high false positive rate because it's very, very sensitive but not specific. And on the other hand, for our suspected IgE-mediated food allergy reactions, food allergy testing becomes absolutely of the utmost importance. And we definitely need to do this to identify exactly what is or is not a food allergy and help them know exactly what to avoid, because once again, those can be life-threatening. And then lastly, when it comes to EGID in general and EOE specifically, food allergy does play a major role. But the exact scope and benefit of food allergy testing is just unfortunately not quite as crystal clear as it is for our IgE-mediated food allergy folks. And so you will see, as I mentioned, stylistic differences. And some doctors will do a lot, some will do a little, and some will do virtually none at all. And it's going to be, I think, kind of a discussion to have with the consulting allergist in terms of which way they want to go, maybe for a specific patient, and what the general philosophy on food allergy testing will be. But a lot of this will be driven as well with shared decision making with the patients, because typically when a patient comes in with EOE, we as allergists like to break down what the dietary treatment options are for them. And for many folks, the elemental diet is a non-starter. They're not going to even be considering that. And they may be willing to do the 4-food or maybe less so the 6-food elimination diet right off the bat. And if so, then they might just say, I'll do that and I'll skip over the food allergy testing. Other patients will want to try to avoid the least amount of foods as possible, and they'll want to get as broad food allergy testing as they possibly can. And so there's going to be some elements of really the art of medicine for those patients to try to kind of come to a good mutual strategy that everyone can agree on. And with that, I think that's it. And thank you very much for your time. And I'd be happy to take any questions.
Thank you, Dr. Choo, for an excellent talk. I would open this for Q&A. So if anyone has any questions, feel free to type in the chat. Sorry, I got muted. Thank you for the great talk, Dr. Choo. My screen muted me. So yes, again, if anyone has any questions, please feel free to unmute yourself or just type in the chat box. I'll be happy to bring it up.
Great. Thank you, Dr. Singh. I see what we have a first question here from Melody. So should we be recommending strict avoidance for our EOE patients, more of a general limiting exposure? So that's a great question. And in general, the thresholds in terms of reactivity are a little bit more forgiving and more generous for our EOE patients than they are for our kind of say, immediate type anaphylaxis type food allergy folks, where they are walking, those anaphylaxis type folks are walking a very, very thin line. And if their inciting dose of say peanut protein is 200 micrograms, they cannot, they really can't play with fire there. They really have to make absolutely sure they're staying below that and making sure that they are really, really reading labels extremely carefully. Our EOE patients usually have a lot more margin for error. And so a lot of times they will be more or less avoiding, say, milk, but then every now and then they'll cheat a little bit, maybe have a tiny bit of ice cream here and there or something. And they usually don't have major symptoms with just very, very slight minor exposures here and there. Obviously, it can be taken too far and they can start to develop issues as well. But the amount of just strictness is not typically as punishingly severe as it is for our other food allergy folks. All right, another question here from Carrie. So when I see EOE patients in my clinic, how long do I recommend they engage in a 4 or 6 food elimination diet? And then the serial reintroduction with EGDs between foods to find the true culprit and avoid over-restricting the diet. Yeah, so also a great question. And so what we've seen typically is that most of the recommendations and guidelines are going to advise about a 4 to 6 week period of elimination to kind of be sure that you're going to be seeing some results from that before you go ahead and have them get reevaluated. Now, in terms of doing serial reintroduction, if someone's trying to reintroduce foods every 4 to 6 weeks, they're probably not wanting to get scoped every 4 to 6 weeks. But just in terms of a general sense of how long it takes typically for us to have an idea about maybe if a food is or is not problematic, we usually are kind of in that range of that sort of month and a half. However, in some studies, specifically like some pediatric studies, they saw things like some pathologic improvement resolution in folks, in kids, even after just like about 10 days of avoiding certain foods. So 4 to 6 weeks might be overkill, but once again, sort of kids versus adults, we are talking about potentially 2 slightly different populations there as well.
Great, thank you. Maybe I'll ask a question, Dr. Choo.
Sure.
This question often comes up in our clinical practice for patients we see with IBS and several food triggers. As you shared a little bit, that often these are non-immunologic symptoms that they have. Mm-hmm. How would you guide us counseling these patients who have access to these commercial food allergy testing? Sometimes they ask our opinion before seeking those tests, which are often out of pocket. And occasionally they just come to us after having those tests And we may find they may be allergic to a whole bunch of food. Should we ask them to avoid all of those? Any thoughts around that? How would you approach those scenarios?
Yeah, sometimes I want to ask how to deal with that myself. It's definitely not always easy. And there's a wide sort of gamut out there, ranging from patients who just happen to be wondering why they have symptoms all the time after, say, lactose ingestion, and then they do that test and then they come to you with some, basically bogus milk specific IgG result that came back positive from an Everly well test or something like that. And then we just sort of describe the phenomenon of FODMAPs intolerance and lactose intolerance, maybe specifically for that individual. And they realize that kind of it makes good sense, and sometimes they're very, very understanding that, hey, look, this is not something that food allergy testing is really helpful for or that I require. And they are happy to walk out of there just sort of with the recommendation to somewhat limit their lactose ingestion moving forwards, perhaps. But once again, with FODMAPs intolerances, things like that, it's certainly not life-threatening, and at most it's really just a quality of life issue. And so I always tell them it's sort of something that they can decide to be as strict as they want to be, and if they're wanting to eat at maybe the best ice cream shop in the city, then maybe they say, I'm gonna suffer a little bit for the sake of the food. On the other hand, I'd say that we definitely, unfortunately, do see some patients who have gotten extremely committed to the idea that they are allergic to tens or even hundreds of foods, and the IgG testing they received and that they paid for out of pocket is only sort of reinforced that idea in their head. And at that point, sometimes it becomes very, very extremely difficult to try to dissuade them of that idea. Usually, if they're that convinced of it, they're usually demanding to see Allergy-Immunology at that point already, in which case, certainly we could try to help re-educate. And sometimes we have to do things like do a lot of real testing to convince them that there's not a true food allergy there. Generally speaking, we as Allergy-Immunology doctors don't like to do a lot of those food allergy testing when the history is pretty clearly not a true food allergy, because of that high false positive rate. But sometimes we have very little choice if someone has just completely restricted their diet to the point that they have no quality of life. And I've seen a couple of patients like that, where they've come in there down to eating maybe like literally 4 or 5 things. I saw a patient who was down to actually having a feeding tube installed because they thought they couldn't eat anything. And it's really, really tragic in many, many ways. And so we try to convince them that they are actually not allergic, and maybe it's just sort of oftentimes it's a very, very gradual process where we just say, look, let's just try to work on adding 1 food a week, 1 food a month to their diet to gradually just broaden it to the extent that they can start to get some decent amount of nutrition and some semblance of something closer to a normal quality of life there. And sometimes it's effective, sometimes it's not. Sometimes we have to work with psychiatry to help out, because oftentimes there's some psychiatric issues going on, some significant anxiety or something perhaps. And so it's not always easy, and definitely sometimes those are the most challenging patients we encounter. But I would say the majority of patients, usually when we sort of explain this and describe the phenomenon and give them a lot of education and teaching on, say, FODMAPs and things like that, then I would say most patients do eventually come around to that.
Mhm. Well, thank you. It's helpful to hear how the experts approach these issues. I'll pause for a second if anyone else has any question. If not, I have many questions, but I'll ask you one last. So you shared that there are skin tests, patch tests, and also blood tests for food allergy testing for EOE and other conditions as well when we think about it. How do you suggest, as non-immunologists, as gastroenterologists, how can we utilize those blood tests ourselves? We would love to send those patients to you. Often there could be some delay from the time they see us to see you.
Mm-hmm.
And I have seen several of those blood tests available in our order sets. And how do you help us? How would you guide us how we should utilize those testing?
Yes, no, that's a great question. And unfortunately, there is certainly a delay oftentimes in getting to see allergy immunology at UCSF, and really, I know every specialty is busy, so certainly not unique to us, but it's, yeah, the sometimes that wait is tough for patients, absolutely. I would say that the kind of depending on the underlying history will kind of help inform whether or not potentially it might make sense to order that food-specific IgE panel or lab that you can order, through UCSF or Quest or LabCorp. So if someone's coming and they're really saying that my history is concerning for that really type 1 immediate hypersensitivity type of a food allergy, oftentimes PCPs or other specialists will get sort of started with the workup and maybe order a food-specific IgE for them. I don't think that's necessarily a bad idea per se if the history is somewhat suggestive of it, at least. I think the main potential sort of caveat there is that if the food-specific IgE testing comes back sort of mildly elevated, it takes a lot of, I think, a kind of experience with knowing what levels are kind of more meaningful and which are not, to know whether you can ignore a value or not, because a lot of times the lab will come back with normal or negative being like, say, less than 0.35 kiloliters per liter for some food-specific IgE. And then I've seen many times a patient has come to our service and they got 0.36 instead of 0.35, and then their doctor told them, hey, you're clearly allergic to this food, you got to avoid it for the rest of your life, and it's just not true almost always. And so so I would say that the food-specific IgE is not a bad start in some cases if you are thinking about kind of that IgE-mediated food allergy, but then the result might be something that you're not really sure how to interpret, and maybe makes you wish you hadn't ordered the test. So I'd say that's one thing to think about potentially, but it's not a bad start in sort of a vacuum. And then certainly, kind of as I mentioned and a few slides ago, I'd say for when it comes to EGID and when it comes to like EOE, those serologic tests are just not really validated in comparison to the skin testing. And so in those cases, if you're seeing an EOE patient in GI clinic and then they're interested in getting food allergy testing, instead of ordering any food-specific IgE, probably better to go ahead and send them our way at that point.
Perfect. Well, thank you so much for shedding light, on these complicated questions, and also I want to thank you for helping us with these patients as well. It's expertise and time is highly appreciated. If there are no questions, I think in interest of time, we will wrap up this first talk. We'll take a few minutes break, and our next speaker will be